The following is a paid advertisement of St. Anthony Hospital Orthopedics. References to any specific product, services, or entity does not constitute an endorsement or recommendation by St. Anthony Hospital, Carroll Broadcasting, or its advertisers. The views expressed by the host or guests are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Welcome to the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. Dr. Godding specializes in joint preservation, reconstruction, and replacement surgery, and brings over 25 years of orthopedic excellence to St. Anthony Hospital and to the Carroll area. For more information about Dr. Godding, his practice, or St. Anthony Orthopedics, go to saintanthonyhospital.org or make an appointment by calling 712-794-5536.
Good Sunday morning, Iowa. It's Dr. Rick Godding. Thank you for choosing to spend a little bit of time with me here today. So I actually kind of lost track of the calendar a little bit and forgot to mention on this show that we had a little public talk, Dr. Dirks and myself, on joint replacement last week at the hospital. Now, what I would say is there were 48 people there, and if there had been much more, I don't know what we would have done. But it was really good, and what we did is we gave our little talks about sort of this is the difference between using the robot and not using the robot, and then compared the various robots that are available. And I can kind of do that here today. So if you have a non-robotic platform, if you're using what we call the standard instrumentation. So standard instrumentation, now there are other things. They can get a CT-based jig that attaches to the end of the bone, and the cuts are made off of that. And there's definitely something to that. It doesn't allow for any dynamic control, in other words, any control at the time of surgery. So the basic difference in this is what the major kind of point that I was trying to get across is we're not doing the same operation more accurately. We're doing a different operation. And what that means is we're still implanting metal on the end of the knee, metal on the end of the tibia, and a plastic block in between them to bear the weight because, of course, metal on plastic, the friction is better. Metal on metal friction just always is going to create problems. They tried that in hips, and then they have pretty well gone away from it. They're back to now ceramic or plastic on metal. I'm sorry, ceramic or metal on plastic. So how is it a different operation? Well, if you just look at the fact of how much more information we're using by having a 3D CT scan rather than just an X-ray, so you're starting with more information. You know, if you're looking at flat X-rays and then the standard instrumentation, so these are just metal jigs, and the metal jig on the femur, you put a long rod inside the femur, and it comes out. You're only putting that rod in there to make the cut, and then you make the cut. Some people are gonna, measure on the X-ray with what we call a goniometer that's going to measure angles and things like that. The number of surgeries that I've seen in my career and that I think is probably going on like that outside of an academic center, because you're teaching these principles when you do that. I don't know very many people that get a long leg knee X-ray a full length standing X-ray from the hip to the ankle, which is what we get with the CT scan. So just starting there, plus the 3D elements of it. So even if you had those long X-rays, and nobody does that except in a teaching center because you're trying to teach the principles. So basically what everybody does is we put the metal rod up inside the femur and you select 5 millimeters because that's the average of the difference in angle between the middle of the bone and the end of the bone. There's usually about a 5-degree difference there. And what you're trying to do is even the cut to what we call the mechanical axis. So mechanical axis drops a plumb line from the middle of the femur all the way just in the middle, just on the inside of the middle of the knee and then in the middle of the ankle. Now, when you're then cutting to match that, then you're not doing anything with the soft tissue, the ligaments and the tendons and things that are going around the knee. And these have, over time, if you have had so much arthritis that you've become either knock-kneed or bow-legged, which is what you typically will do, then the ligaments, if you're knock-kneed, then the ligaments on the inside are stretched out and the ligaments on the outside of your knee, looking from the front, are loose. If you are bow-legged, then the ligaments on the inside of your knee are tight and the ligaments on the outside of the knee are loosened. Now, those ligaments, they tighten up over time, and then it's very, very difficult to get them to loosen up unless you release them off of the bone. So if your operation is intending to get the mechanical axis reproduced by the bone cuts 5 degrees to the end of the femur and then 90 degrees from the plane of the tibia, because that's straight down, then you put your trials in there and then you start releasing ligaments off the bone in order to what we call balance it, balancing the knee replacement so that it moves smoothly. And you do that until it feels just about right. And there's nothing wrong with that. I mean, this is how, I've been doing it since, that's how I learned to do it in my first knee replacement that I ever was involved in, which would have been my third year in medical school in 1996. So that's the same way we were doing it 30 years ago. Well, okay. So imagine, what computers were like. I mean, we just had gotten the internet in the library at the medical school at that time. Nobody had internet at the house, and nobody had smartphones. They had flip cell phones. And to look at how technology has advanced all around in every aspect and think, oh, well, now they have this 3D CT model uploaded into the robot, and that's not going to be any different. So it's going to be different. There's no question. And so instead of the mechanical axis, what we do is during the operation, before we make any cuts, and we've drilled a couple of holes in the femur and in the tibia, and we've attached reflecting discs to them. And these reflecting discs reflect back the position of the bone in space to the robot. And then we take it kind of looks like a pen, and it's got some more of these reflecting discs on the end of it. So it's long, it's about a foot long, and it's got these reflecting balls in sort of a pattern that is, again, recognized. If you can look online, you can get a cartoon video of a Mako knee replacement so that you don't have to look at the actual bone cuts if you want to. I wouldn't recommend looking at the bone cuts if you're thinking of having a knee replaced. So we take this essentially pen and we place it on about 100 or so points on the knee, and it shows us where it wants us to grab these points. And then we press it, or we put it there, and then we press the button with our foot, and then we've got this exact model of every little nook and cranny of that knee uploaded into the computer and then cross-matched with the 3D CT scan that we've already uploaded, from which you would get a couple weeks before the surgery. Now, once we've done all that, then what we do is we stretch the ligaments on the knee until they feel like they're at their natural capacity. So, in other words, how far can that ligament stretch? And then, obviously there's a kind of an end point there, and you don't want to go past that. And I've never seen a rupture or heard of one. I think you'd have to put a whole lot of pressure on there. But you're getting it. You're getting those ligaments that are shortened, stretched out back to where they kind of want to be. Then you're saying, you put those numbers up, and it will tell you, okay, so the ligaments on the inside of the knee are stretched to, let's say, 3 millimeters, and ligaments on the outside of the knee are stretched to 1 millimeter. And then so you can start doing things. You can start this is before we made any cuts. You can start, the robot will show you where the knee replacement is going to go, and then it will allow you to move. You can rotate in any direction. You can move it, what we call varus and valgus, which is just kind of in the horizontal plane, moving it 1 degree or another, or the opposite, and you can move it front to back. So you just have this amazing ability to, with the level of accuracy of 1 millimeter or 1 degree, actually 0.5 millimeter. Sometimes we'll be doing it and I'll be like, so you're trying to match out to 1 millimeter on each side, and one side's 0.5 millimeter and the other side's 1 millimeter. I'm like, look, that level of detail isn't even possible with the standard instrumentation. So the standard instrumentation, on the tibia side, you take a clamp on the tibia. There are various ways, but this is the most popular way. And you line that up with your eyeball and your thumb to the second toe. And then you bring it out a little bit away from the shin bone so that you can have what's called a posterior slope, because the tibia wants to be in a slope going backwards a little bit, like 3 degrees. And all of this is just essentially eyeballing. You're just eyeballing it. And then when you put where you want it to cut, you're counting on how accurate you've been on all this eyeballing, and then you drill a couple of pins in and hold a cutting jig. So there are no cutting jigs with the robot. So the robot arm has a saw on the end of it, and it is going to cut exactly where I put in where I want it to cut. It's also going to protect you. There's some vessels in the back of the knee, and it won't let you get into those. That's nice. I've never seen that happen with or without the robot, but theoretically possible. So the type of alignment, it's sort of what we would call a kinematic alignment. It's not exactly kinematic alignment, but it's more towards a kinematic alignment than a mechanical alignment. So again, the mechanical alignment is going to line everything up with predetermined plumb line from the midpoint of the hip to the center of the ankle. With the kinematic alignment, we're going to line it up where your knee wants to sit based on the tension of where those ligaments are now. Then we make the cuts. Then we put the trial in. So the trial is just a reusable mock-up, metal and plastic mock-up of the knee. So you put that in, you say, well, how's that feel? How's it feeling? Okay. And when you've finished that and you think it feels good, then you do the final implanting. And of course, because we're using a Stryker triathlon knee, which was the best-selling knee in the world before Stryker Corporation bought the Mako robot. I don't know, 7 or 8, maybe 10 years ago now. And we've had one here since I got here. So this is my 6th year here. So we're coming up on 6 years of having the Mako here. And it's just demonstrably different in the outcomes. First of all, the Stryker triathlon knee, prior to being implanted with the Mako, because of the specifics of the design, I can talk about that on another day. Because of the specifics of the design, it had the largest percentage of what we call forgotten knee. That's when you have your knee replaced and you just totally forget about it. Like you never think about it. Like I don't even think about having had my knee replaced because the way this knee is designed, it functions. The mechanics of it is so perfect that I just don't even feel it. Now, that's not everybody. It's not everybody. It's not. But the highest percentage of that was the Stryker triathlon knee that we used prior to the company picking up the Mako robot. So now we have the best selling and arguably the best functioning knee now being implanted in a way that is just completely different and way better. Since we don't have to release ligaments off the knee, off its insertion after we put the replacement in, that reduces your postoperative pain. Very, very rarely now. I believe I've done 2 manipulations in the 600 or so knees that I've done since I got the robot here at St. Anthony's. What a manipulation is if you're not where you need to be, if you're not at 90 degrees by 6 weeks, we'll take you to the operating room, give you a little bit of anesthesia. It's very quick. We just bend the knee, and then it usually works out pretty well, and people get the motion that they had not had. We just don't have to do that anymore. It's not something that is required because we're not taking off the ligaments and because everything is put in exactly kinematically, meaning matching your motion. That's what kinematic means. It's matching your motion rather than matching the exact architecture that you're shooting for, which is derived from averages, right? So everything is personalized to your knee. Now with the hip, it's even, putting the socket in is the place where you can really get into trouble with the hip. But also the robot allows you to check the leg length. And that's one of the big problems that after a hip replacement is leg length inequality. And the robot allows you to test that before you're done as well and adjust it if you need. Placing the socket, if you're using the standard instrumentation, you got to have the patient exactly, the pelvis itself, not just the patient's body, but the underlying pelvic bone needs to be exactly 90 degrees to the floor. And, especially in bigger patients, there's a little bit of give. If you have a little bit of extra weight, your bones are jiggling around in there a little bit more. And then you will take what is basically a ball that goes into the socket, and it has a handle on it, and then it has 2 rods. One of the rods you eyeball to be parallel to the floor, and the other rod you eyeball to be 15 degrees from the spine. And that's how you put the socket in there. And again, look, hips and knees are well-regarded operations. People love them, especially hips. They're even easier. And now, of course, my partner, I don't do total hips. He does total hips coming through the front with the robot. I think there's 6 or 8 places in Iowa you can get that combination of an anterior hip with the robot. but there's only about 12 or 14. They weren't even able to give me an exact number, but there's definitely way fewer than 20 Mako robots in Iowa. And so what we're able to do is just as advanced as it can possibly be. If you went to Mayo Clinic and had a hip or a knee replacement, I'm 100% sure that you can get a Mako hip or knee there. I don't know that everybody there uses it. And like I said, there are competing robots, but really none of them, that's a whole other discussion. None of them really do what the Mako does. They're just, a couple of them are really just putting the metal cutting jigs in using a robot arm instead of using the robot arm to do the cut with the saw on the end. And there are some patent reasons for that, patent protections that the Mako has. But yeah, I mean, if you think of anything else, and really, so 1996 is when I started doing total knees. Total knees had been being done for, in that manner for at least 20, 30 years before that. So you're literally doing the operation the same way it was done 60 years ago. And again, it's a good operation. A standard instrumentation total knee has an 85% success rate, success defined as people who are either very satisfied or satisfied. And so that doesn't count the people who are somewhat satisfied or not satisfied. So that's the 15%. That drops to 5%. Because 95% of the patients with the Mako are either satisfied or very satisfied. So you drop, nothing's going to be 100%. That's just, things happen. Planes crash, despite everything, things just happen. But to have 95% of your patients either satisfied or very satisfied is great. It's very satisfying. Because if you're doing 100 or so in a year, which is what I've done most of my career, if you have 15 patients a year who are either somewhat satisfied or unsatisfied, that can be tough. It's much better to have 5 or fewer of those a year than 15. And, it takes a little longer. It takes 10, 15 minutes longer to do the knee. The hospital makes less money on the knee because they have invested in the robot, and then they have to pay for what we call disposables. Those little discs I talked about, they cost money every case, but a long time ago, St. Anthony's committed to having the very best technology that they could have for the patients and let the rest of it sort itself out. And that's what has been happening, and that's been great. It is a wonderful, St. Anthony's, another thing I love about working at St. Anthony's is when I talk to the CEO, that's the end of it. He is the buck. Alan Anderson, he's very good. He's been here for, I think 4 years now. But there's nobody above him. There's no corporate structure. We're not part of a chain. We're not owned by any other entities at all. It is completely self-owned hospital, and the board of directors, there's nothing above the board of directors and the CEO that are right here in Carroll, and so all of the operational decisions are made here. There's nobody else to answer to because of the corporate structure, and that allows us to do some pretty cool things. And it's a great culture. It really is a culture of patients first, for sure. So anyway, that's my chat for today. I hope everybody is enjoying the little bit warmer weather, and I'll be back next week, and you just have a blessed week, Iowa.
This has been the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. For more information about Dr. Godding, his practice, or St. Anthony Hospital Orthopedics, go to www.santanthonyhospital.org or make an appointment by calling 712-794-5536.